Assalamualaikum warahmatullahi wabarakatuh, and good afternoon, ladies and gentlemen, friends and colleagues. Welcome to this afternoon's Oncology Summit, meeting the promise of cancer in Malaysia. The agenda for the next 2 days have been shared with you and is also available for download through this virtual platform. This Oncology Summit, organized by the Galen Centre for Health and Social Policy with the support of Takeda Malaysia, aims to continue our ongoing discussion on how we can meet the promises of improving cancer care and overcome the gaps affecting effective treatment and care for cancer in Malaysia. Ladies and gentlemen, the reality is that significant treatment gaps in cancer care do exist. With costs of healthcare becoming increasingly higher, we see that cancer patients are forced to move to government hospitals when their insurance runs out or their own or family savings are exhausted, placing more burden and demand on public hospitals. We hear that there are many new cancer therapies becoming available. They are novel, innovative, effective, and often spares patients the need for chemotherapy, which is often regarded as toxic. But it can be hard for patients to access these new treatments, which sometimes requires innovative financing models, patient access schemes, and industry-sponsored clinical trials. We can do better and help increase access. Friends and colleagues, we need to bring together health and non-health sectors to develop innovative, localized solutions and partnerships for cancer care to tackle the growing burden of cancer. When you look at the current cancer data available to us from the Ministry of Health, it is very clear that we definitely need more work in this area. Most importantly, we need patients, their families and caregivers to voice out and help share their thoughts with us to see how we can do better. How can we improve Malaysia's 5-year survival rates for all types of cancer? What kind of barriers exist today, not just during the COVID crisis, but even before that, which continue to impede treatment and care access? How can we improve on the survival of people living with cancer in Malaysia? These are some of the issues that I hope will be discussed by our speakers during today and tomorrow's sessions. And I do hope that all of you will take this opportunity to participate in the discussions that are going to be part of the deliberations in the summit. But, before we move on, may I remind our participants who are watching online to make use of the Slido facility to park your questions so that they may be answered by our panel. I think the link is on screen and you can see there with the QR code as well as the Slido details there. Please do take full advantage of this opportunity to ask the questions to our panelists later on. And this is open now. You can send in your questions and we'll go to them during the Q&A session later. So as you know, Takeda Malaysia is supporting this afternoon's event, and we are fortunate to have a committed partner working in the oncology space in Malaysia. I would like to invite Mr. Igor Gomez, General Manager and Takeda's Cluster Head for Malaysia, Singapore, Vietnam, and the Philippines to say a few words of welcome. Over to you, sir.
Okay, thank you so much. Good afternoon, everyone. It's a great pleasure to be here today. Really welcome to the Oncology Summit 2022. Before we start, I would like to say a special thanks and to express my gratitude to the Deputy Minister of Health, HB Dato, for taking time from your very busy schedule to attend this event. I would like also to welcome and thank all the experts, panelists in the summit for getting to discuss and share your valuable insights and understanding for the cancer care that we have nowadays in Malaysia and how we can improve the cancer landscape in the country. I'm sure we are going to learn a lot today from their insightful discussions and presentation. My heartfelt appreciation also to Mr. Azul from Galen for organizing this such important event. So I'm very happy that we are going to have this kind of discussion. So let me briefly share an overview regarding Takeda. Takeda, as you might know, is a Japanese company, is a patient-focused organization with values-based driven, R&D driven as well. It's a global pharmaceutical industry. We have a very clear mission to bring better health and brighter future to people worldwide. Our passion is really totally linked with the patient centricity, and this is something that we are pursuing, let's say, since 1781. So we have, let's say, more than 240 years of distinguished history in Japan. So next slide, please. Thank you. Our signature of patient assistance program and market access was introduced in the organization in 2016, 6 years ago, as part of the Takeda's Access to Medicine initiative that was also implemented in 2016. In 2019, we had the acquisition of Shiaw, and we expand our presence over 80 countries, globally speaking. So we have a presence, of course, in Japan, US, Europe, emerging markets, and everywhere we have a very strong presence and we have a very strong commitment to improve access and to really have the patients as in our focus. A little bit about our corporate philosophy. So our purpose, as I have mentioned, is better health for people, brighter future for the world. We are strongly committed to discover and deliver the life-transforming treatments guided by our commitment to patients, our people, and the planet as well. Our North Star is the Takedaismo, which was implemented since 1781, so more than 240 years ago, which is integrity, fairness, honest, and perseverance, brought to life based on PTRB, patient, trust, reputation, and business in that order. So we have a very clear culture in Takeda that all decisions must be taken into consideration. Patient, trust, reputation, and business. And all employees must follow that order when we are dealing with our business activities. So a very high level overview regarding our R&D focus. In Takeda, we are focusing on developing highly innovative medicines in 4 therapeutic areas: oncology, rare disease, neuroscience, and gastroenterology. And we have also had some target markets and target areas under the PDT, plasma-derived therapies, and vaccines that contributes to making a difference in people's life. We are very excited that we are going to launch our first vaccine in Takeda next year in Malaysia for dengue. So we are working a lot in terms of disease awareness. We are very excited that a lot of people will be benefit from this vaccine, especially because we know a lot of countries in Asia are considered as endemic countries. Our employees, they are fully committed to improve quality life for patients and to work with our partners in healthcare. So next, please. Okay, so let me give you a very overview regarding our oncology business. So in oncology, we are aiming to deliver the novel medicines to patients with cancers worldwide through our commitment to science, breakthrough innovation, and passion for improving the lives of patients as well. This singular focus drives our aspirations to discover, develop it, and deliver breakthrough oncology therapies in hematology areas, but in solid tumors area as well. So patients with limited or let's say ineffective treatment options motivate Takeda every day. I think this is really the passion and our commitment in oncology area. All employees are fully committed to outsmarting cancer so that more patients can be benefit from the treatments and have access to life-transforming medicines. We ensure a tight connection from research R&D to development to commercialization to rapidly meet the unmet needs that have under the cancer area, optimizing our ability to bring transformative medicines to the patients worldwide. For, let's say, in the last decades, Takeda Oncology has led in the development of target therapies for hematologic malignancies. Let's say we were pretty much focused on oncohematology area. Our pipeline is built on that foundation with treatments in development for blood and solid cancers right now. Our demonstrated leadership combined it with cutting-edge science through multiple platforms, partnerships, and therapeutic approaches, enabling us to bring innovative medicines to the cancer patients. So caring for people living with cancer is, is very complex, is an ever-changing landscape. Every day we are inspired, motivated, and driven to do more to support the patients worldwide, and of course in Malaysia, Philippines, in all Asia countries as well. So we believe the best way to achieve our aspiration, that is we aspire to cure cancer, is by working together. So thank you again for your valuable time today. I really invite you all to enjoy this summit today and tomorrow. And as a company, we strongly believe that together we'll be able to improve the patient's life with cancer. So thank you so much and wish you all a great event.
Thank you. Thank you so much, Igor. And while today's event is focusing on cancer, I must say it was exciting to hear from his remarks just now about the possibility of a new dengue vaccine on the horizon, something to look forward to. Ladies and gentlemen, for your information, participants for today's event, there have been more than 200 registered participants, and this is something of a welcome development, but also indicating very clearly the interest that people who work in the health sector across the country on the issue of cancer. So the government of Malaysia has repeatedly emphasized its commitment to the implementation of improved cancer control and prevention strategies to reduce incidence, mortality, and increase cancer survival. In addition to that, ownership of the cancer issue has been repeatedly emphasized by not just the health minister, but also the prime minister, in which the ownership must go beyond health, but also into other sectors, such as labor, finance, urban planning, and education. So with that, I must highlight to you that we are honored to have with us on the same stage here this afternoon, with us the Deputy Health Minister, Yang Berhormat Dato Aaron Argo Dagang. I have to say, Dato, thank you so much for being here with us, and may I say that we are all relieved and thankful for the recent announcements by the Ministry of Health on the COVID-19 SOPs. So with that, may I invite you to the podium to deliver the keynote speech and help launch the Oncology Summit. After you, Dato.
Thank you. The organizing chairman, and also with me on stage are three specialists from local universities. Ladies and gentlemen, terlebih dahulu saya ingin mengucapkan ribuan terima kasih kepada penganjur, yaitu Galen Centre for Health and Social Policy, as well as Takeda Malaysia, kerana menjemput saya untuk bersama-sama dengan para peserta di summit ini, walaupun kita berada secara hybrid. Penghargaan juga diberi kepada semua speakers yang akan membentangkan beberapa tajuk dan isu penting berkenaan dengan kanser atau bara di Malaysia di bawah tajuk Meeting the Promise of Cancer in Malaysia, Cancer Care, sorry. Now, I was given to understand that both Galen Centre for Health and Policy as well as Takeda Malaysia are independent organizations that promote and improve health and social conditions in the country through research, advocacy, and networking with stakeholders. Ladies and gentlemen, we are aware that the burden of COVID-19 on our health systems was unprecedented, or that the care gap exists. These care gaps become barriers or challenges across the different phases of disease journey. Example, from prevention through diagnosis, treatment, and post-treatment support. For example, one of the major care gaps in prevention aspect is awareness and understanding of cancer and its causes. In treatment and post-treatment aspects, it is the financial challenges, palliative care, and psychosocial support. During the peak of the COVID-19 pandemics, hospital priorities changed. For example, diagnostic services, appointments, and elective surgeries were postponed. And a large number of our healthcare facilities, services, and personnel had to be repurposed to cater for COVID-19 patients. It has been a hard time for all, and many lives have been lost. We should not be discouraged, but help to address the care gap in our cancer services. As all of you know, cancer is one of the most important NCD ataupun non-communicable diseases globally, where the number of new cases and death increase yearly. In the past 2 decades, the number of new cancer cases increased from 10 million in year 2000 to almost 20 million in the year 2020. This is a huge increase of almost 100%. Cancer death also increased from 7 million in the year 2000 to almost 10 million in the year 2020, an increase of 43%. The Malaysian National Cancer Registry reported an increase of 11% new cancer cases over the 5-year period. Now, these rising numbers will become a major health issue and growing burden on people with cancer, the communities, and the country's health care system. About half of all cases are due to breast, colorectal, and lung cancers, which account for almost 43%. It is unfortunate that many cancer patients in Malaysia are diagnosed late at stage 3 and 4. Overall, cancer survival rates in Malaysia are still low. The lowest survival rates are for lung, trachea, and bronchus cancer, so about 11%, followed by liver 12%, pancreas 14%. The other cancers such as colorectal, breast, prostate, showed better survival rates ranging from 51% to 73%. Survival rates are dependent on various factors, including stage of cancer at diagnosis and constraints or challenges faced by people with cancer. Ladies and gentlemen, medical treatment costs in Malaysia is high, and we have yet to realize its goal of providing universal health care to all Malaysians. But instead, we provide services through a dual public and private health care system. The Ministry of Health runs the public health care facilities and provides heavily subsidized services to the public. And now about 65% of patients seek health care services in public facilities, which charges very minimal fee. Currently, there are 6 hospitals, 4 university, 6 government hospitals, 4 university hospitals, and at least 27 private hospitals with cancer facilities. And there are about 128 practicing oncologists throughout Malaysia. Thus, this gives us a ratio of 1 oncologist to every 250,000 individuals. However, the number of oncologists has tripled in the last 20 years. The Ministry of Health issued policies to provide screening and early detection for cancers, particularly for breast, cervical, and colorectal, and oral cancers in health clinics. The Malaysia's National Cancer Control Plan helps implementing these policies by encouraging people to make life changes and reduce their cancer risk. Despite all these positive initiatives, there remains a gap in the financial burden and accessibility of cancer care in Malaysia. The government is also working to increase access to drugs by making them more affordable to patients. Oncologists visit hospitals in states that don't have oncology services to lend their expertise. And Clinical Research Malaysia helps clinicians to conduct research and collaborate with top scientists around the world to bring innovative treatments to cancer patients. Ladies and gentlemen, Malaysia has many resources available to people with cancer that has made valuable difference to thousands of people with cancer and their families. The Social Security Organization, for example, SOCSO, provides social security protection to employees and their dependents through the Employment Inquiry Scheme and the Invalidity Scheme. It helps to provide screening vouchers, pensions, rehabilitation services, and financial aid to employees facing cancer. The Ministry of Health also introduced the PKB40 scheme that provides clinical examinations for breast and prostate cancer, as well as incentive for completing cancer treatment. There are also several NGOs that can help people with cancer by providing information, prevention, screening, treatment, and support, such as the National Cancer Society of Malaysia, the Majlis Cancer Nasional, the Breast Cancer Welfare Association, and SACAT, and many others. Now, ladies and gentlemen, the last 2 years of COVID-19 pandemic has demonstrated to us the need to make the necessary investments and commitments in healthcare, as they have a direct implications and impact on overall population health, outcomes, and resiliency. Increasing investments in cancer care is not only about treating the disease, but saving lives and premature death. Ladies and gentlemen, with that note, I'm happy to launch today Oncology Summit as we work together in realizing our summit theme, meeting the promise of cancer care in Malaysia. Thank you.
Thank you, Dato, for your words and insights into the issue of cancer in Malaysia. We are appreciative of the support given by you and the Ministry of Health, and do hope that we are able to count on you at the Ministry as we get closer to Budget 2023. Talking about budget already, Dato. So may my colleagues accompany you. As I understand you have to leave us soon. So so thank you so much for your speech. Please. Yes, if you like, Dato, you can join us if you like, and then leave whenever you're ready. Okay, Dato, please. Okay, thank you. And I'm not joking there, Dato. I'll tell you, it's Budget 2023. We're going to be looking to you. So thank you so much for taking the time and being with us. And as you've all noted, ladies and gentlemen, we have the privilege of having quite a large group of specialists with us here this afternoon who are joining us from their respective organizations. And let me just say that I haven't seen some of these people in, almost a year plus, like actually physically. So I'm very happy that this has happened. Yes, so we have with us Professor Dr. Aishah Taib, who comes with us from the University of Malaya Medical Centre, who is also the director for UM's Cancer Research Institute. Also is Professor Datuk Dr. Fuad Ismail, who is a consultant oncologist with the Malaysian Oncological Society and is attached to HUKM, the hospital and University Kebangsaan Malaysia. And also we have Professor Dr. Gan Shaozi. Should we call you Prof. Gan? Yes? Jinjin, okay, Prof. Jinjin, who is a professor in internal medicine and clinical hematology at Faculty of Medicine, University of Malaya. We were also expecting actually Associate Professor Dr. Nimala Bupati, but unfortunately she is unable to make it this afternoon due to a bout of food poisoning. So I do hope you'll share with me our prayers and thoughts for her speedy recovery as well as that of her family. So these are the people that we have with us this afternoon for this summit on oncology. And I do again would like to emphasize that please take advantage of submitting your questions on the Slido app so that we can ask questions. So Dato, that offer also goes to you. If you want to ask some of these specialists, it's not every day we get a Deputy Minister of Health to ask questions. So inilah kena grill sikit lah, right? Okay. Definitely. So Dato, so for the first presentation, we will hear from Prof. Aishah, and the way we're going to do it this afternoon, Prof, is, I know we're used to the webinar format, but what we're going to do is we're going to give you 15 minutes for your presentation, and then we'll go through the other presentations as well, and then we'll go to the Q&A session where we'll ask questions and so forth. So without further ado, Prof. Aishah, I hand it over to you for your presentation. Go ahead, Prof.
Okay.
Thank you, Dato. So thank you so much for being with us.
Thank you very much.
Yeah. Have a nice celebration. Okay. See you again sometime.
Yes, inshallah.
Thank you, Dato. I will. Thank you, Dato. Thank you so much to Dato YB, Dato Aaron, for joining us this afternoon for the launch and his keynote. So without further ado, I hand it over now to Prof. Aishah for her presentation. Go ahead, Prof.
Okay, thank you very much, Azrul. It was a much pleasurable thing to do when we can meet physically, isn't it? Because most of the time, we are on the webinars. And I think for the last 2 years, we've gotten so used to the webinar, it is becoming a habit, right? Okay. So actually, I wear 2 hats today. So I'm also the Vice President or Vice Chairperson of Together Against Cancer, which is an advocacy group that represents patients as well as carers, as well as healthcare providers who are very interested in cancer advocacy in Malaysia. So let's move on. Okay, I think I don't have to mention this because I think Dato Aaron has actually given us a very good overview about cancer in Malaysia, but just for you to see that we have the top one, which is breast cancer, then we have colorectal cancer, lung cancer, and then of course we have lymphoma, and thereafter most of those cancers are almost similar in their percentages. So this is for everyone. It's not just for women, but this is for everyone. All right. So we also know that I think Dato Aaron mentioned about the difference in the 5-year survival rates by cancer types and how low it is if you compare it to other developed and upper middle income countries, where we can see that for breast cancer, our 5-year survival rate is about 67%. And you can compare that to Singapore, where they are about 80%. And you compare that to Japan, it's 88%. So this is the difference in survival rates that we have across the country, different countries. So that's another representation of the same thing. So maybe I want to touch upon the cause of death in the country, right? Because somehow cancer has been diluted over the years, always taken as one of the top 5 causes of deaths in Malaysia. However, if you look at the data, it's usually non-aggregated data. So cancers have been treated separately. So breast cancer, lung cancer, they're all separated. And hence, when you recalculate, if you look at the premature mortality in Malaysia, so if you look at it and you recalculate and you aggregate the data, you put cancer together, we're actually number 2. So the cancer is actually the second cause of premature mortality. And why we have to focus on premature mortality? Because this is people in their 30s to 69 years old. These are people who are fairly they are the ones managing their families, their businesses, and losing this group of people is actually quite a large impact to the country. So you can see, of course, ischemic heart disease is always number 1, and number 2 is cancer. Right, I think we don't have to go into much details. I think everybody knows when you say the word cancer, it equals the dollar signs, right? So financial toxicity is a major problem. And you can see that a lot of the expenditure differs across the different health sectors. So in the private sector, a lot of it is financial catastrophe because of medical treatments. But when you go to the public sector, they also fall into financial catastrophe, and usually it's the non-medical costs. So there are people out there who do not even have anything to eat when they have to have treatments in a facility which is almost free treatments. And they have problems even coming for transportation and all that. So just to focus again on the health expenditure of the country. So we always say we have a very good public health system that will sort of become the safety net for the country, for the poor. But actually, if you look at the expenditure, it's mainly in the private sector. So there's about 60% or 50% in the private sector. And it was so surprising that you can see the out-of-pocket expenditure is very high. It's about 35%. And more surprisingly, why is the insurance, the part of the pie is only 8%? It's very low, actually. We would think that a lot of the people using the private sector would be using a lot of insurance to get their treatments done. So 8% is pretty low. Yep. So I'm not going to go into too much details because we only have 15 minutes, but I thought, just to share with you really delays in presentation, delays in treatments, delays in getting diagnosis. This is a major problem that we have in the country. So, of course, it looks very complicated, but essentially the cancer journey is quite complicated. So you have to understand the trajectory of when someone presents from the community, and then going to see a doctor, getting diagnosed, getting treated, and then after that, what happens in the follow-up. So at any point of this journey, people have a lot of challenges. So if you look at the delays that we have, essentially this is a way to measure the quality of care. How do you measure timeliness? So there are data points that is already published and actually known globally that we should be measuring in Malaysia. Are we really doing a good job in getting our patients timely diagnosis, timely treatments, and so forth? So the delays that we see, you can see this is a study in 6 public hospitals. Presentation delays, about a third of them. Diagnosis delay, about 42%. And then treatment delays, about 36%. And this is like diagnosis delay is actually even referring within a different system. That means within the hospital, if you are referring in the same hospital, you may actually experience diagnosis delay. So there is a lot of inefficiencies in the health system. And then when we say, okay, when you want to do cancer care, you must invest a lot of money. But actually, it's not really money. It's actually efficiency. Because delays within the health system can be improved without increase in cost. Because it's just like designing a pathway that the patient is able to travel through safely in a timely manner. So I thought I'll just put this one up just now, but sorry, I cannot get it back. Okay, so Together Against Cancer is actually a mixed group of people who are very interested in the quality of cancer care in the country. And we have a mix of health professionals, survivors. So our president is Mr. Wong Kwan Sing. He's a prostate cancer survivor. And we have other people, oncologists, even people who are experts in patent laws, in financing. So we invite people out there who are interested and who have knowledge and would like to share to improve the advocacy that we should have in our country. So this is a very difficult slide, but essentially you can see now what is the trajectory of the disease, what are the issues that our patients face. Actually is throughout the whole journey. Our members are people not just in the M40, also B40. So we hear a lot of stories from them about how challenging it is to navigate the whole system. So navigation information is actually one of the main challenge if somebody is diagnosed with cancer, or even before the diagnosis, when somebody has a symptom or an abnormal test, what do they do next? People don't know what to do with this. And then again, care is available, but is it really timely? So there are a lot of centers. In fact, most of the basic care you have in most of the Ministry of Health hospital or even the university hospitals, timely diagnosis is the only factor that is the problem. The diagnostic services is there, but whether or not it's efficient and is able to get on with adequate time, that is the problem. The third one, of course, access to affordable care. So what happens really, we always hear that, oh, you know, you go to a government hospital, most of the treatment is subsidized. However, it's only subsidized to a certain extent. So if you are a patient who's been diagnosed and you're only going for your first treatments, and these treatments are curative, it is likely that it is subsidized. So the treatment cost may not be as high as compared to if suddenly you know you now have cancer that has spread, because the drugs that can to control the disease well, especially if the patient has cancer that has spread, the drugs are usually new. They are patented drugs, which are very costly. Some may cost something like 15 to 20,000 per dose, right, Prof? So this is the problem that our patients face in the early part of the diagnosis when they have cancer that has spread. So we hope that, in our country, the patients all present with the advanced disease. So what happens? That means the recurrence rates are higher. So when they have recurrent cancers, again, they need to go for another treatment that is probably not really subsidized. And these treatments are quite costly because these drugs, again, may actually be still patented. There are no biosimilars or generic drugs available. Right? So, of course, I put there number 4, silver economy, because as the country ages, there will be more cancers. And the aging population have their own challenges already, as we say, financial challenges, even navigational, travel, support and all that is another kettle of another pot or something else, okay? Sorry, okay. So just to mention here about why the timeliness is a difficulty, because the lack of oncologists, lack of surgeons in the country, and it's not equitable in terms of where people are located, isn't it? So if you're located in the Klang Valley, the ratio of oncologists to the population is actually much lower compared to, of course, if you go to the northern states and all that. So this is a nice paper, a report done by the Malaysia Travel Council that actually sort of details about the numbers of oncologists, breast surgeons for breast services. So please go look up this article to understand how bad the situation is in terms of the numbers of practitioners, the professionals that actually manage patients. And this is one of our biggest issue for timeliness. At the moment you already have a problem where people need to navigate a very, very difficult health system. Then there is an additional step. If you are seen by a private GP, for example, with a lump or a symptom, and this person is a B40 and they need to access a government clinic, but with a referral letter from the private GP, they are then charged the first class fees. So these people are the people who really need the subsidies from the Ministry of Health. That means they should be treated as not like third class, tapi, not first class fees, of course. So this is a very, I think you've tried doing this, Azro, for the last I think was that 5 years? 4 years, right? We have failed to do anything about this. So I really hope that, you know, the policy makers are listening, because if you need to change the act, change the act. Because why are you doubling up this, the need of having 2 doctors when you just have 1 doctor who sees the patient and just move the patients on, right? Okay, so there are a lot of wishes from the Together Against Cancer. We want to see more public and private partnerships. And we really want to see this decoupling of the financing and the services aspects. Because we have to understand what is the available services that we have in the country to provide the best care or enhanced quality care, or for maximal care. I think it's okay, because maximal care, if you can afford it, go ahead. But then we should at least have best core, or we call it enhanced quality care, for everyone, if we can, in this country. All right, and then if you have these services across public as well as private practice, how are we going to finance it so that it will be accessible to everybody at the basic level? Okay, all right. I just wanted to show you when I said, you know, what is basic, limited, enhanced, maximal. This is actually a very clear-cut, stratified guidelines by the National Comprehensive Cancer Network, which is American-based, but it's very well thought of, and is evidence-based guidelines for everything, for screening, for diagnosis, for treatments, even palliative care. And they actually stratified what would be at the basic level that you should be doing. So that when you say basic level, quality of basic level, that is what quality is. But in this case, this is breast cancer treatment. You can see that we are actually functioning at the enhanced level in Malaysia, even in the Ministry of Health. Because in someone who has locally advanced cancer, if they have the HER2 type of disease, they get trastuzumab and taxane. So we are actually functioning at the enhanced level. So how do we use these guidelines? Because maybe if you are in a very rural part of the country, you may not have ability to do neoadjuvant chemo. That means having chemo first, then having surgery. In that situation, you should do a mastectomy for that patient. And that is practicing at a limited level. But even though you're at a limited level, that level should be of quality. So the country, I think, has different tiers of care among the different hospitals. So I think you can choose whether this hospital is a limited care cancer hospital, but at high quality, or an enhanced hospital at high quality, or even in some private practice where people have limitless insurance, they may be practicing at a maximal level. All right, so I'm not going to go too much into details, but essentially we have members that actually share their journeys. And I think the video is out there somewhere. I don't think we should really go into too much. Yeah, we had a nice discussion during the October month last year. And Crystal, one of our members, actually shared her journey as a patient who was diagnosed initially, and then she had a recurrence, and she had this HER2 breast cancer. So she had paid about 400,000 already during the time when she was talking to us about her treatments. And then, of course, the things have slightly changed because, of course, we know that when you have non-patented drugs, cost of treatments will come down eventually. But are we doing it quickly enough? Okay, these are some of the tips that she put up. So look out for the video that we have in, I think you can find it in our Breast Cancer Resource Center YouTube channel. Okay, it's somewhere there, but you can read about it and understand that M40 people also have a lot of issues. You know, they sell their houses and all kinds of things to sort of, you know, pay for their care. EPF is not enough, okay? And the income tax relief is also not enough. So they do have these medical expenses on serious diseases, but it's capped at about 6,000. I'm not sure about this year whether it's increased, but 6,000 is nothing compared to 400 over 1,000 ringgit that she had to pay. Yeah? Right. So this is something I thought we would just share about the drug trastuzumab. So trastuzumab in 2018, it was actually not even 2018, it was even before that. I think it was 2014 when it became a biosimilar. I mean, it was no longer patented and there were biosimilars available, but we didn't bring it fast enough into the country. So it took a while for the prices to come down. And you must remember, patients need to take this for a year. So they may be spending something like 100,000 over ringgit just for curative treatments. So we hope that by next year, the prices will go down further. So you can see it's almost like halving of the price, every year or of 2 or 3 years. So I think, because we want it to be accessible for the patients. And whether or not we can do this, that's why I think Together Against Cancer, we are trying to be the watchdog, sort of looking at the list of drugs that are now off patent and to see how we can work with other organizations. I think National Cancer Society is also doing a lot of work with this, getting to see whether there are any other local manufacturers or even international manufacturers that can bring in these biosimilars and generic drugs legally through our National Pharmaceutical Regulatory Board and all that. So really, I think the aim I'm just trying to say here is sometimes it's not about putting more money. Maybe it's the efficiency of how we can do things better. Okay? So this one is the problem lah. When somebody has a recurrence, they are still using new drugs that are efficacious but very expensive. I didn't go into too much details about the type of drug. I think Prof will be the best to do that. So this is my last slide. So we feel that timely care really is something we can already do because we are already we do have a health system. We have a health system that can diagnose, can screen, right? But are we doing it in an efficient manner? So maybe the increase in cost is not so much, It's more of efficiency, right? Improving the quality of care, that sort of thing. And again, the policies that are not helpful, like the, Akta fee, all that, I think we should try to read something about it, and hopefully the politicians are listening. If the, elections coming, maybe you want to bring this up, yeah? Okay. And then of course, we want career pathways for cancer professionals, the other cancer professionals. Even though we don't have enough oncologists, we want psychologists, we want genetic counselors, we want specialist nurses. These are all people that will fill the gaps of care for the patient. And again, mentioning about the competitive pricing of non-patented drugs, this is something I think if we are more efficient, I think the prices can come down quicker than what we're doing now. And again, the patented drugs, I think that's a global challenge. I don't think we can do much at this point, but we are always hopeful that, Malaysia now being a representative in the World Health Assembly may actually be able to do more about this. Okay, and then of course, as mentioned, we can actually provide quality, basic or enhanced care in Malaysia. We just need to ensure the quality is better. We have the people and we have the equipment. We just need to improve the efficiency. And again, healthcare financing, maybe we should ask for more money lah. Yeah, I think our public funding is so poor right now. We should increase. Okay, and then again, we must have this focus on cancer. I think I have no problems with getting ischemic heart disease down because everybody's dropping dead, young people. But second cause of premature mortality is cancer. And then insurance, how we can increase 8% is nothing, I think in that frame of mind. I think there could be more investment from the insurance companies, right? And then how are we going to reduce the out-of-pocket expenses? And again, tax rebates. 6,000 ringgit will not go far. Maybe they should give some proportion, a higher proportion for people who have non-curable disease. They are paying through their, they're actually paying quite a lot every year. And tax rebates would be something that would be very useful for these people. So I think that was my last slide. So I mean, now as a research institute punya head, we are doing a population health study. We're trying to reduce the gaps in the care of cancer in a small committee where we're piloting it in a very small committee in Taman Medan. I think we can bring freebies into Ministry of Health because in the past, access to free mammograms, access to free HPV testing, it's not that easy, to get it into a clinic kesihatan. But there are other organizations, other stakeholders that are providing that already. It could be from the state government, it could be from Ministry of Women's, but how do you get it into the healthcare pathway? So my take on this is you have to strengthen the health system. Efficiency, I think that's the key. Maybe you don't have to add too much money. Of course, you need money, but you can still do the efficiency part better, I think, at this point in time. Okay, thank you very much.
Thank you so much, Prof. Aishah. You know, you were wondering when you came in just now, like this hours of time, what am I going to be talking about? And honestly, there, there, there were so many questions that I wanted to ask, really, and I thought of abusing my privilege as a moderator to ask them, but I decided maybe not because we want to give chance for other people to ask. But you did a great job of setting the stage on presenting to us the general issues and challenges of access and affordability in cancer care. And I think, you know, honestly, you have raised so many issues there that I think are low-hanging fruit, you know, that we can work on. You know, the questions on timeliness. Are we actually providing timely cancer care? You spoke about the aging population, that we're actually one of the worst countries, really. We're not really prepared for it. And most importantly is the injustices, or perhaps some of those gaps that we're talking about in terms of affordability, which you have mentioned, which we can therefore look at addressing through the structures that we have today. We don't have to reinvent the wheel, we can do something. So I'm going to put a pause on that, and I see there are already questions on Slido already, quite fast and furious there, so we're going to park that still, because we're going to address that later on. But I want to give a chance to Dr. Fuad, who is coming from us from HUKM and is going to be talking about, and this is the thing, we've heard a lot of the what we want here coming from Prof. Aishah. And Dr. Fuad, we're asking him to answer us about balancing what we want and what we need in terms of access in cancer care. So, Professor Fuad, over to you, sir. Go ahead.
All right, thank you, Azrul. Great job, Aishah. Yeah, I was just wondering why you looked at me when you said not enough to eat. Okay, I'm wearing two hats today. I'm from UKM. I'm also wearing the Malaysian Oncological Society hat. And I sort of speak or some of the things that we discussed. Now, Aishah mentioned this. Cancer causes the greatest loss of healthy life in the world. And because it tends to strike people who are still in their working years, so there's a lot of life loss and also economic loss to the world. So there is a cost to cancer. So the cost is not just in terms of lives, the cost is in terms of economics, and they estimate that about 17% of all healthy years lost in the European Union is due to cancer. So that's a lot, that's a really big chunk. And the good news is that we are getting better. The cancer survival rate is improving for many cancers. You can see that across the board, that the graph is going down. So that means there's less deaths from cancer. So that's good overall. But how are we doing? So only. This is breast cancer survivor, Aishah already mentioned. To the left of the graph are those developed countries, Australia and so on. So their survival rate tends to gravitate towards 90%. We, unfortunately, are on the right side of the graph, and our survival rate is about 65 to 70%. We're actually lower than Thailand. We have two people who you at least compare with, Thailand and Singapore. Thailand, because we hope that we're better than them, because Singapore, we want to try to catch up with Singapore. So that's us with, in the same group as Thailand. We're not doing too bad overall in certain cancers. So for colorectal cancer, we're quite close to Singapore, doing a little bit better than Thailand, but you can see that we're still quite way behind Australia. For pancreas, now this is not representative of Malaysia. This is from the Penang Cancer Registry. So for pancreas, somehow we're doing better. I have some doubts about these figures because all the other countries are hovering around 10%. And we can see for lung cancer, we are hovering around 10% when Australia is doing twice as well as we are. So when we talk about the general pathway of cancer, we are not just talking about the treatment of cancer. Although I'm an oncologist, we really have to talk about primary and secondary prevention as well as tertiary prevention, which is prevent the disease, treat the disease well, and then prevent complications. Basically, something like that. Okay, so this is primary prevention. Now, if you think about what are the most preventable things, the first and top on the list is still tobacco, still estimated to cause maybe 25–30% of cancer. So if you can get rid of tobacco, you can get rid of smoking, then you should be able to reduce many cancers, not just lung, head and neck cancers, bladder, cervical cancer, and so on. So this is UK. And you can see that after many years, the level is plateauing. And so you'll never be able to get it down to zero. So it must be a certain reasonable figure. So Malaysia, we're improving. Our tobacco rates have come down. So we are about 20+% now. The target was 15% by 2025. So it is very unlikely we're going to reach it, especially as about 40% of the men still smoke, and that figure hasn't come down very much at all. So big target, but probably not achievable. We need to talk about controversial stuff, and I'm trying to raise some controversies, like maybe going towards less harmful tobacco or smoking elements like, I'm not advocating this, but like e-cigarettes and whatever it is. You know, you can't get them to smoke, ask them to smoke something safer, yeah? And don't drive so fast, basically, bring down your speed limit, something like that. So, screening is very controversial. I know that a lot of people will advocate screening. I probably get killed for saying that breast screening is a bit of a waste of time, but you do need to screen a lot of people. 2,000 women screened for 10 years, then you reduce one cancer death. So what Aishah says is actually very relevant. We've been focusing a lot on screening. Okay, you found something on your screening, but the rest of the pathway is very slow. So you may have found a small tumor, then by the time they actually get the treatment, it's actually quite a big tumor. So the emphasis should perhaps be moved a little bit away from screening and into making the system more efficient. Lung cancer is very interesting. The numbers to treat or the numbers to screen before you get an improvement in mortality is actually lower than breast cancer. But overall, the absolute risk reduction is still only 0.4% of all lung cancer mortality. So yes, you can detect some, but the overall mortality will not reduce by very much. So you have to look into colon and cervical cancer screening, maybe different ways, occult blood instead of colonoscopes, and HPV screening instead of pap smears. Maybe those would be things to think for the future. Now, secondary prevention, we think about what are the treatments available. Surgery has been around a long time, radiotherapy, chemotherapy. The last two are the problems. These are the new therapies. These are the bill busters, basically. Yeah? And we have to look at, I do both radiotherapy and chemotherapy, so kena promosi radiotherapy sikit. Surgery is estimated to cure about 50% of all curable cancers, radiotherapy another 40%, chemotherapy is 10%. And this was a paper from the Wales group looking at the radiotherapy needs for Wales, so it is quite relevant. And you can see that here, it's a very small slide, even I cannot read it. So our radiotherapy needs, we are still a bit behind. We got about 35 to 37 machines, we need 13. But we also have to remember that many of the machines are actually very old. So the access to radiotherapy is very poor, and radiotherapy centers are mostly in the Klang Valley and major cities. So if you're in the Klang Valley, you can really go anywhere, and you can get treated basically like tomorrow or the next week. So other areas have limited access, very limited. Pahang, Terengganu, Sarawak. Sarawak has got good centers in Kuching, but it's such a big state that the other areas have got very limited access. Pahang still hasn't got any, Terengganu hasn't got any. And these are very, very big states. As a cancer treatment, this is a cheap modality because in UK, radiotherapy only takes up 5% of the cancer treatment. And if you're thinking that you're curing about 40% of cancers, that's a small budget. And it only takes up 1% of the total health budget. 1%. Yeah? 5% of curative cancer treatment and 1% of total health budget. So it is something that we should advocate, and many studies have shown that radiotherapy is effective. It can help in the advanced setting, and it can also help in in curative therapy. So this is our situation. You can see there's a whole bunch of dots around the Klang Valley. The red dots are are private centers. The yellow ones are university, and the blue ones are MOH. So you can see that the East Coast is severely underserved. So what we need is to essentially move up the services and get access throughout the country. So it's very, very difficult for somebody to come from Terengganu or Pahang. They have to spend about 6-7 weeks here for curative treatment. So it is a big burden for them, a big burden for the family to accompany, especially if they're elderly. So, if you have a few extra centers, it's still going to be in the long run cheaper than getting very expensive new chemotherapy drugs, and would be provide much more better access for our population. So Going to drug is such a big controversial issue because there's so many new drugs. The innovation in cancer drugs is coming very, very rapidly. There's so many new drugs, and every year we get more and more drugs. So if in the 1990s you may get 1 or 2 blockbuster drugs in a year, we may get 10 or 15. In fact, there's so much data that's very difficult for a practicing oncologist to keep up with all the new data and new drugs that's coming up. So that's the rate of new drugs coming out. There's probably 1 or 2 a month now rather than 1 or 2 a year. This is an example of how good they are. They can improve your cure rates by about 15% or at least keep the cancer away for quite a long time. So graphs like this are quite common with the advent of the new drugs. So you can see here, this is a little bit busy, but you can see something like chronic myelocytic leukemia where you live 5 years, and then with the new drugs, then you have a quadrupling from 5 years to more than 20 years. So some of the new drugs are really amazing in terms of curing or improving the care for cancer. It's just a matter of which are the new ones that we should prioritize and which are the new ones that really give you the bang for your buck. Okay, so I'm a big movie buff. So Uncle Ben said, remember with great power comes great responsibility. So with great new drugs comes great money. So you can see that the cost of drugs have been increasing, and in this graph you can see that for the last, say, 5 years, most of the new drugs will come with a price tag of more than maybe $100,000. So getting a treatment that costs $1 million is still unusual, but we are getting treatments which actually cost that much. So our wage is probably increasing by about 4%. I mean, if you work with kerajaan, then you get satu kenaikan gaji with maybe RM100, but the price of drugs is going up like 10 times that rate or more. So the bad news is this, that the cost in everywhere is going up, in UK, in Ireland, throughout the world. Yeah. So if you start on a low base like us, the incremental cost will probably be much more. So the medical costs will put all of us in jeopardy, including the US. US spends a lot. They spend now almost about 18 to 20% of their GDP on healthcare, compared to the many parts of the world, the more social economics like Germany, UK, and so on. They probably spend about 10%. I think that is our target. Our current expenditure for health is only about 4%. So we need to perhaps doubling it is a bit challenging. I think maybe about 50% may be doable for us. So everywhere is going up, and Malaysia is really no different from this. Yeah. So just a scenario, they estimate that Ontario in Canada spends about 46% of the budget on healthcare, and growth of healthcare expenditure is going up by 4%. The growth in revenue is going up by 4%, but the healthcare is going up by 6%. So they think if they don't curb these things, that by 2030 they'll be bankrupt. And because the graphs are like this, the expenditure is going up really, really rapidly. An expensive drug in the 1990s would be about 3,000, and now per month cost, if you actually pay the full cost, something for lung cancer would be about 30,000. So that's 10 times over a period of about 25 years. I think our gaji tak naik 10 times lah. Yeah. And as Aishah has alluded, spending more doesn't mean you're getting better healthcare. This is a review of the quality of care throughout the world, and they look at the different countries. In general, those socialized countries where they have socialized healthcare system like Netherlands, they are doing better compared to the US. US consistently rate about 7 or 8. If they survey 7 people, usually US will be number 7. They survey 8, US will usually be 8. Compared to Australia, Canada, Japan, and so on. So spending more doesn't mean better healthcare. You need to spend wisely. So what do we need? We need more doctors, we need more support staff, psychologists and so on. We need more treatment centers, blah, blah, blah. But again, if you watch Greatest Showman on Earth, it's never enough. If you give, the UK was given a big drug budget and it was never enough. So this happened. David Cameron's flagship cancer drug fund became a waste of NHS money because people started spending money left, right, center. So much so they had to curb certain things, and then they said that you guys are spending too much. So some of the drug need to have, not say taken away completely, but need to be spent more wisely, more within certain indication. Okay, so that's why we need to consider this thing, what we've been advocating, value-based medicine. We want to treat everything. We want to have all the latest drugs, but we can't. However you look at it, money is still limited and we need to use it wisely. So the value of something depends on where you are. So if you want to get married, maybe the value of a diamond is very high to you, but if you're stuck in the desert, you throw away the diamond for a bottle of water. Okay, so the cost effectiveness or WHO guidance, we've been fighting for this. We say that the drugs which are cost effective, we should really fight for it. What we need to do, for me, is that we need to increase our base treatment, not so much the innovative drugs. The base treatment is easy to move up. So if somebody comes up and say that if you've got recurrent breast cancer or something, you should be able to get a second line treatment with a taxane easily, or even gemcitabine without having to pay out of pocket. And these are cheap treatment because they're old drugs. And they can still give you good quality and very, very reasonable treatment. An elderly gentleman was thanking me profusely because I managed to get him paclitaxel from the Kebajikan, and it's a 20-year-old drug. And he just couldn't afford even that. So, yeah, so we know this from the WHO, and we must not forget all the other aspects of cancer care, especially palliative care. Now, there's a lot that we can do to cure patients, but many of them come in advanced disease, and palliative care is really important, and there's nothing like making your last month comfortable, helping the family, helping the patient. That will do a lot more than just buying expensive drugs. So palliative and supportive care will be very important, and we are still underserved in this aspect. You know, it's very difficult to send patients home, very difficult. The family are under great stress to help the elderly at home, but if you can help to support them at home, I think again we will improve access and improve their overall, maybe not so much survival, but their overall quality of the last months of their lives. Yeah. So systemic therapies, the standardized treatment that we have fought for, where we produce a systemic therapy protocol so that these are the drugs that we want to be made available everywhere. They not necessarily be the latest, but they're efficacious and they are good value for the money. And we also need to, what Aishah mentioned, shorter intervention, procurement costs, getting the drugs in quicker, like trastuzumab. You know, we need to be more efficient in getting in the biosimilars, and so that this cost savings can be given to us. Yeah. So sometimes radiotherapy, I've mentioned, we need to do simpler treatment and then leave the high technology machines to the more specialized centers. You don't need to have IMRT for everybody. Sometimes simple radiotherapy close to your house is exactly the right drug for you, so to speak. Yeah. Okay, so I'm going to skip some of these. Okay, so this is the evidence-based medicine. We need to follow it. I am happy that the Minister just now mentioned that it's been used for our COVID as well. So evidence-based medicine is very important, but we need to up it a little bit and also add value to our base medicine. And we need to work together. Aishah mentioned this. So it is a big problem. Patients who are referred outside and then they are charged a premium in MOH hospital, then they come to us, and we don't have as many drugs as MOH sometimes, so that is difficult. But it should be more seamless, and I think there are a lot of groups working towards this. So we need to look at all the different aspects. What is the minimum clinical benefit that is for patients, and any interventions that we do. So, and many people have done this, many groups, and this is an example, choose wisely for India. So they look at all the different interventions that has come over the last few years, and it may be something simple, like say like, you don't need to do CT scans for stage 1 breast cancer, but in a private healthcare center, they will do CT scan. They not only will do CT scan, but they will also do PET scan for you. So that is actually a weak waste of resources, and this is something that that doesn't help the country overall. Yeah. Okay, so I mentioned this, and I am just going to say about the difference in improvement in survival by just giving early palliative care. So palliative care and supportive care is very, very important for the patient, and it is associated with cost savings. Yeah, so it's not that it is something that's going to cost the country a lot of money, but it will actually save the country. So this is an example that they say that if you do palliative consult early, that overall the cost to the patient care will become less, and the cost to the country also will become less. So where are we now? What do health services do when faced with such catastrophic economic problem? We have to look at ourselves, right? So this is from Alice in Wonderland. Would you tell me, please, which way I should go from here? So it depends which way you want to go. If you want to go the path of expensive treatment, then that's a different path. So Alice says, I don't care very much where, then it doesn't matter. So you need to know what are we trying to do? Are we trying to advocate for the most expensive treatments, which will push a few people to better life? I'm not discriminating them, but it is easier to raise the base. So that's, I think, the path that we should go. So we need a sustainable healthcare. We need our guidelines. We need good drug indication. Sometimes we repurpose drug, negotiate prices, and so on. This is what I think. We need to restring some of our cancer screening strategies, move towards maybe more towards the second part of the patient journey, diagnosis and getting treatment in quicker. The current drug formularies should be improved. That means raising the base, getting a lot more of the old drugs available to people before we embark on purchasing a whole lot of new expensive therapies. The use of innovative therapies should follow the same guidelines for value-based care, and we should improve radiotherapy access. I think this is something that patients are really, really lacking, especially in the East Coast. So thank you very much.
Thank you, Prof. Fuad. And I might say that highlighting the importance of value-based healthcare and definitely using the issue of value to help in decision-making is key. And it certainly helps to balance out, in terms of the question of what we need versus what we want, but also how do you decide on that? What are the key criteria? And I'm glad that you brought that up. And I must say, though, you're one of the first few speakers that I know of who have brought in pop culture, including movies and honestly, Alice in Wonderland. I love that. It's remarkable, and it definitely does have a lot of lessons to be learned from even those quotes just now. And let me just say before I pass on to the next speaker that we really need to have a look at that Choose Wisely India table that you shared, because that's quite important to, when we talk about lessons learned, avoid the mistakes that others have made, and most importantly, to optimize on the resources that we have and avoid waste. It's important to have that in front of us. So thank you so much for sharing that. I can see there's some more questions coming in from Slido, so we'll deal with that shortly. But at this point of time, we have our last speaker before we go into the Q&A session, who'll be talking to us about the opportunities in cancer care. And in this case, we are looking at an area that we don't hear enough about, I think, which is blood cancer. And we're fortunate to have one of Malaysia's respected hematologists here with us, and we have Prof. Gingen. Over to you.
Thank you very much. Indeed, it's an honor to be here and to be invited. As you have mentioned, a lot of time when we talk about cancer care, somehow the blood cancers are not being focused on. I suppose in general, because it is a little bit less common compared to the solid tumors, but equally important. So I was given the task to discuss what are the gaps and opportunities that we can do for our blood cancer care. So as already mentioned, there is obviously an urgent need to address the burden of cancer care, and we know that, as Prof. Aishah has mentioned, that it is the second leading cause of premature death. And to be honest, majority of the patients with cancers are actually within the productive age. They are young, especially in blood cancers patients. So I hope you can see that I just highlighted. This is also the same diagram or figure that has been shown by Prof. Aishah, but I highlighted, if you were able to see, lymphoma, which is a type of tumor or malignancy that is being treated mainly by the hematologist, is actually one of the top 5 common cancers in Malaysia. And not falling behind is also leukemia, as we know. All right, and similarly, female as well. So if you were to look at the age group, you could see that lymphoma and leukemia are actually one of the top cancer in a very young age, and also in a very productive age, age ranging from 25 to 49 years old. So again, I just want to show here that again, this diagram has been shown by Prof. Aishah, but I'm just focusing on leukemia as well as lymphoma. You could see that if you were to compare the survival rate of Malaysian lymphoma patients as well as leukemia patients, if we were to compare with our neighboring country like Singapore, and of course with UK, you could see that our survival rate, 5-year survival rate and 1-year survival rate is actually quite poor. And of course, you could also see that the age, the survivor among the different age group, although the younger tend to do better, but we really want them to do even better. So what are the gaps? I think it has been mentioned quite a lot of times, and it's mainly the same in blood cancer as well. You could see that late diagnosis, you could see that lymphoma, if it's been diagnosed later, they have a poorer survival. And it's, even though this is for solid tumor, but I just wanted to show that even in UK, if your patients with lymphoma has been diagnosed of stage 4, generally you could see that again their overall survival are poorer. Multiple myeloma is also another blood cancers that not very common, but it is something that one should be focusing on as well. This is a data that we collect from our hospital. You could see that more than 50% of them actually present at advanced stage, and the overall survival of 5 years is only 45%. So what are the gaps? It's again showing that a lot of our patients are presenting late. So what can we do about it? I think it is important for us to address how we can educate not only the patients, but also the physicians as well as the general practitioner, what to look out for, what are the things that they should be thinking. Sometimes, for example, multiple myeloma, a lot of them, more than 60 to 70% of them actually present with bone pain or fractures. And that is something that we can start to educate our orthopedic, for example, or general practitioner about thinking about something about multiple myeloma. So of course, similar, the gaps are treatment inaccessibility or the lack of treatment centers. Again, Prof. Fuad have also eloquently shown us that the lack of treatment center, it is even worse for centers for patients who can access for hematologists. You could see again, generally, you could see again, there are majority of the treatment center that has hematologists are basically on the West Coast or Peninsular Hospital. If we look at the East Coast, very few, only 2 center or 3 actually in HUSM, Terengganu, as well as Kuantan. And if we were to look at East Malaysia, it's even worse. Yeah. So it is not just the lack of treatment centers that has clinical hematologists that patients with blood cancer can go to, and the distance to travel is also an issue. Besides this, besides having clinical hematologists, as one of the curative treatment for blood cancer, for certain blood cancers is actually bone marrow or stem cell transplantation. The transplant centers are even lower than what we have seen. So we'll talk about lack of oncologists. They have more than hundreds. But for hemato-oncologists, we have only so far about 70. So it is really, really not many, okay? So as I mentioned, limited transplant centers, variable or unable to access the novel or targeted therapy. Certain centers, certain hospitals may be able to access to it, obviously private hospital. But sometimes sometimes the smaller hospital may not be easily available to access to some of the targeted therapy. And I wanted to also mention that I think a lot of clinical trials, which, as you know, in blood cancer, there have been leaps and bounds of advancement in novel drugs, immunotherapy, bispecific antibodies. Those are not easily accessible, but I think a lot of time, a lot of pharmaceutical company has actually forgotten or somehow skipped Malaysia as a center for clinical trial. And I think it is very important for the pharmaceutical company to realize we have huge number of patients. We have, as Prof. Fuad and Prof. Aishah have mentioned, our facility is just as good, all right? And I think it is something that the pharmaceutical company should think about, not to skip us, but to provide us and our patients the availability of participating in a clinical trials. And as we know, some of the clinical trials do translate into a significant or a bad improvement in overall survival, as well as clinical improvement and quality of life. So this I've mentioned. I think we have to think about increasing training for and instill interest of our doctors in hematology or oncology, for example, increase the cancer center in East Coast as well as East Malaysia, and to somehow to entice our younger generation into serving the people in East Coast as well as East Malaysia. And as Prof. Aishah has also mentioned, that I think we have quite a number of generic as well as biosimilar drugs which are going to be much cheaper. I think it is important for us to allow all the Ministry of Health should look into approving the generic or biosimilar a bit sooner. For example, as Prof. Fuad has mentioned, chronic myeloid leukemia, the tyrosine kinase inhibitor has significantly changed the paradigm treatment for CML. And patients who are on tyrosine kinase inhibitor, for example, imatinib, has actually really improved the patient's survival. They have almost normal lifespan now. However, we are the country which are one of the latest to be off patent. So our availability of having a generic is also much later. So I think we should have also more collaboration between the public institution, the academic as well as private health institution, because a lot of time I think we can share our knowledge, we can share somehow the availability to do investigations or as well as certain diagnostic tools or services as well. And as I mentioned, we should have more visibility for in the international scene for clinical trials. I think, as also mentioned, I think we should not forget about psychosocial and psychosocial support. There has been some studies that to say that you can see that huge number, more than 2/3 of our patients actually have psychological stress, not only patients, but also their carer. I have also done a study looking at carer. Also, we have found that they have huge incidents of anxiety as well as depression, looking after their loved one. So we know that the quality of life is affected by not just the diagnosis, but also sometimes the side effects of the therapy, and also it can affect their self-esteem. So of course, this is heightened even more during the MCO as well as the COVID-19 pandemic. And also, besides psychosocial, I think financial support, as you have mentioned, obviously a lot of innovative therapies are very expensive, all right? And in blood cancers, CAR T cells, if you have not heard, it is something that if it's biopharmaceutical, it can cost up to millions. But there are ways that we can actually bring down the price by having our own lab, our own GMP lab, and learning from certain other companies of learning technology transfer and making our own CAR T cells. And of course, there's hematopoietic stem cell transplantation. It can be curative, and again, it can be expensive, especially in private centers. So these are the gaps, and I think again, opportunity is for us for psychosocial support. I think we should recognize that. I think obviously we have lack of clinical psychologists, okay? They are very important. I think perhaps we should look into encouraging people to do more clinical psychology in helping our cancer patients as well as their caretaker. we should look at more support group, especially in blood cancer, which I must admit, we do not have many support group, although there is some aims to do that. And also, I think with the COVID pandemic, we have learned now how to do virtual or webinar. I think a lot of technology can also be incorporated into providing resources for our patients. And of course, healthcare, I think somehow we can improve and enhance our healthcare system to provide even better care for our patients. I think that's all. Thank you very much.
Thank you, Prof. It's quite educational for me to see this because, as mentioned just now, we don't see enough of the dimensions, perspectives, but also even the treatment availability for blood cancer, and to see the way it's been portrayed there, and also what is basically a shortage of related specialists is something of a concern. It's not just for blood cancer really, but it's across the spectrum of cancer care in Malaysia, but specifically in terms of a quite large population of patients with these cancers, which is still needing to be addressed. And we've seen the survival rates there. I was just looking at it just now. It's just slightly above liver cancer, and that's quite low already. And this is something that we could do better, especially when we see the progress that's been made in other countries. So thank you so much for your presentation there. So, ladies and gentlemen, let me highlight to you again that Slido is open. You can send in your questions now and ask your questions to our panelists here. If not, I will take full advantage and ask my questions to them. So don't let me get away with that. So let me ask here. We have the most popular question here, which is concerning, I think this is soalan cepu mas, very often asked, which concerning the ratio of oncologists against patients, and very often it's always talked about is the government punya service, right? And it's felt here is totally disproportionate because you have more oncologists or cancer specialists in the private sector. Now, a lot of people say this, a lot of people point that a lot of specialists leave government service for the private sector. In fact, if I'm not mistaken, Prof. Fuad, the largest concentration of oncologists in the country is actually on Penang, right? In Penang Island, because they have quite a number of hospitals there. So what is the ideal? What is the ratio that we're supposed to be looking at? I mean, how do we overcome the problem that's been highlighted in this question? Let me ask Prof. Fuad first, and then I'll go around the panel. Go ahead, Prof.
This is soalan cepu mas lah. I mean, it cuts across many different specialities, so not just oncology, but for us, chicken and egg situation. You're in government service, too much work, you cabut, get less work, more money. Okay, that sounds good. But then you also, when we train people, we always ask them, are you going to at least help us to get the level up, spend a few years in the service? But people have got their own thoughts. So the current thinking is that in UK, they suggest for new cases, 250 new cases per oncologist. 250 new cases, all you're supposed to see. So if you get 30,000 cases, so you can imagine, even if a third of them goes to the oncologist, not just the surgeon, so that we do need quite a lot of oncologists.
So it's also dependent on disease burden? Or?
Yeah, it is strongly dependent on disease burden. And now, that ratio used to be 315, then it went down to 250. It might be down to 200 now. The reason is that especially if you're doing radiotherapy, the radiotherapy is much more complex now. So you do need to spend a lot more time. So if you see about 4 new cases a week, then maybe that's in general enough. Yeah.
Okay. Prof. Aishah, you're still in government service? Not heading off to the private sector anytime soon? But
I'm
what do you
already
think?
doing private one.
Yeah, but
Yeah, we're partly private.
Partly.
No,
But
I think,
what do you think about this question?
yeah, I think this is where I think the health reform has to come in, because I think we've been trying to do the same thing over and over again for the last 30 years, and it's not working. So that means, I think you have to recognize the trained oncologist or the trained subspecialist surgeon. They spend so many years training, And, but at the end of the, where will they go? Most of them will go private. Because because they spend so long training, they're also getting older, you see. Do you think they can stomach the increase in the cancer cases that they have to manage? They can't. So this is a no-brainer. It's not working. It's just like, you're being an idiot trying to repeat things again and again.
Einstein.
Einstein said that. So maybe there should be really a serious look at seeing where there are issues about not enough capacity, whether they should be looking more at the human resource, like maybe private oncologists can work in the public sector and vice versa, or maybe you treat the oncologist or the subspecialist surgeon as a commodity that can move from different sectors, and yet they are paid well,
This is a very important point here, because the issue of staff retention, human resource retention here is something that is basically a drain on Malaysia's healthcare system. And perhaps one of the disadvantages here is that we look at these healthcare as in two separate parts,
Exactly.
Public and private. And then in some aspect, one side cannot work in the other, but the other side can. And so we have a situation that even when the private sector healthcare professionals want to work in the public sector, they can't because of existing regulations and policies. But during COVID, it was possible to do that because they longgarkan, they made it flexible. But the issue here is healthcare reform. So the health minister is now talking about a white paper for health reform, which is hopefully going to materialize for real this time. And, you also touched on reform in your presentation. I know you said just now in terms of opportunities there, but specific to some of the areas that you've seen, where would you like to see improve on in terms of this issue of insufficient manpower? I mean, you pointed it out almost from your first slide.
I'm probably one of those few who continue to stay in academic and do not practice private at all. So I think I can understand why there is so difficult to retain the young ones or even sometimes the senior one because of the attraction in monetary sense from the private side. So I think a lot of them do want to stay in public and to serve the community, but I think sometimes for whatever reasons, they felt that that's the path that they have to take. So I think with health reform, I feel that the government should look into, besides what you guys have mentioned, somehow allowing both sides to work in each center. But I think they have also to think that they should increase certain incentive, not necessarily monetary, but other incentive for those who are more inclined to stay in the public institution. And not only that, as a person who works in academic center, I also feel that the government should also remember that treatment accessibility should be at least attempted to be equally distributed. I feel in university, some of the drugs patients have to pay. I'm not sure about oncology drug, but for hematology, blood cancer drug, a lot of our patients who are being treated or managed in university, they have to pay out of pocket unless they are pensioner or government servant. But even that, there is multiple layers of forms and approval to obtain that drugs, which can be freely available in Ministry of Health, although they have certain budget. So again, I feel that that can be improved. And to ensure that, because academic center are also treating many cancer patients, and we should not also putting a lot of obstacles for our pensioners or our government servants in having to go through many steps before they can obtain the necessary drugs.
It does seem sometimes that it's like a jumping through an obstacle course, you know, trying to get access, right? You're going over one hurdle and go to the next one. And patient navigation is a very important aspect, and ensuring that patients are able to not only have access, but adhere and complete the treatment. And that's a whole new discussion. And we're going to be fortunate enough to hear a little bit about it tomorrow's session. But, you know, already we're describing some of the complications and the hurdles for us to be able to provide that. So I have a question here. One of our colleagues from the Ministry of Health the other day was complaining to me that very often there is a lot of discussion about cancer. We always talk about the supply side, you know. We don't talk enough about the demand side, meaning the patient side, you know. And many of the outcomes that we talk about, that we want to go and achieve and we want to be able to see from improving cancer care, is dependent on patients being able to be informed and take advantage of the services that have been provided. So, Prof. Aishah, I'm going to ask you, because you see your frontline, you see patients all the time, you know what drives patients to come forward, to even get screened and diagnosed at the very beginning, and then there's always a gap. So, what's the problem? You know, because a lot of patients are coming late, they're presenting late, but many a time that's because they were earlier diagnosed, but then refused to get treated. So tell us about some of these challenges and how we can deal with it. Go ahead, Prof.
Yeah, I think number one is always the push factor, you know. If you have a disease and if you get it in treatment and everything in a smooth sailing way, I'm sure they will have their things done, right? But it is actually quite difficult to access. So for example, if they have a symptom, number one, they may not know that this is a suspicious symptom. So the health literacy in the country is actually quite low. And we were just sitting around a table for iftar and they were just exchanging information about screening for cancer. So what comes up? Tumor markers. So generally, all those people out there who are generally well-informed, have a bit of money, they do their own screening. What do? Tumor markers. They have never heard of fecal occult blood test. They've never heard of HPV testing. So it means that the literacy on health screening, especially cancer screening, is actually very low in the country. Okay, and furthermore, once they have a problem, where do they go to? I always have patients who end up with a gynecologist. I'm a breast surgeon, but the patient always end up with a gynecologist somehow because people think that breast cancer is treated by gynecologists. So actually people don't know where to go, who are the doctors that will be helping them through the journey. And I think one commodity that we have not really used in Malaysia is the family medicine specialist. Because everybody thinks out there in the primary care is all just doctors who just finished their MBBS, spent 20 years, 30 years working and they didn't update themselves, right? But there are actually specialists working in the primary care sector. And I think this movement of family medicine specialists should be really focused on getting our patients educated about the right screening tools. And we must remove this tumor marker culture that is wasting a lot of individuals' money because it's out-of-pocket expenses again. And it's not going to detect the cancers early. A lot of people will say, oh, you know, if I didn't do that test, I wouldn't have found my cancer. But it was that cancer early stage cancer?
Dr. Fuad, you seem like you have an opinion on this point. Did you want to contribute that?
Yeah, I think tumor markers have been really oversold. I mean, we don't believe it works in screening. So they say that they've gone for screening. Luckily, I did my tumor marker. But they actually had bleeding. And the CAA was normal. But that's no longer screening because you are symptomatic. The purpose of screening is to detect those who are not symptomatic. So it's not quite correct, the perception of the tumor marker. So again, you know, as Aishah said, it's a waste of money. And they could have done something better with the resources. But it's a very popular thing by the private centers.
Yeah, you're definitely right. I think we see that quite a bit in some of those private labs offering screening, right? And then there's also the tumor markers. But honestly, around the dinner table, at least my place, we don't talk about tumor markers during dinner, but certainly during iftar. So, but that's this is one of the challenges here in terms of patients coming forward, knowing when to get screened, and most importantly, what screening should they take, what should they go after, what they should look out for. So, for yourself, Prof, dealing with non-solid tumors, I mean, where do you see the hurdles concerning patients' knowledge and being able to access some of those services provided for blood cancers?
For blood cancers, generally, we don't have much of tumor markers, really. So I think the challenges is, I think, quite a number of even our family medicine doctors or general practitioners, they are not very well versed with blood cancers. I guess perhaps it is something that is not as common as solid tumor. So I think that has to be addressed from medical school. And not only that, and perhaps we should have more education or webinar or even conferences targeting at our family medicine specialists. So I think that's something that a little bit lacking. I think that's a gap. Second is that patients sometimes also do not understand what is blood cancer, right? And most of the time we are talking about chemotherapy, and generally chemotherapy especially for acute leukemia is usually very intensive. And a lot of time patients tend to back away because it's too intensive and it's scary, and patient has to be admitted for a long period of time. So I think again, the fear of patients, and they tend to then come in later or tend to seek alternative medicine. So I think, so by the time they come, it can be quite late. So that is another gap that I think we should be looking at as well.
Well, the problem in Malaysia is very often linked back to health literacy as well, where we are struggling with a third of the population having low levels of health literacy and not knowing what to do with the information that they do get concerning health, and to then be able to act on it. So we're asking quite a lot sometimes. We provide the buffet of cancer care, and then asking them to pick, and then they can't, But let me ask you, because we have a question there on the Slido there concerning what we've heard quite often about, which is the long waiting times for even basic imaging, for example, a CT scan or MRI, which very often happens in the public health facilities. I don't know how it is at but definitely we hear quite a bit in the Ministry of Health's main facilities. So how do you think we can help reduce this burden, but most importantly, shorten the waiting time? I think somebody mentioned just now about perhaps utilizing the resources in the private sector to do some of this screening. What do you think, Prof? Is this something that we can do today?
I definitely agree with what Prof. Fuad have mentioned. A lot of time, the private patients or they are being investigated, CT scan, then subsequently PET-CT scan, which basically going to give you similar information. It would have been better just PET-CT scan in the first place, and then sometimes they will then order MRI or the CT scan of the neck, and then after that CT scan of the abdomen, when it could be done in one setting if they have examined the patients or have certain diagnosis frame in their mind. For blood cancers, obviously for lymphoma, we would do a PET-CT scan, and I think that should be the standard of care. And as you've mentioned, there is long waiting list, and in UMMC, it's also no exception, but probably a little bit faster. I think
what is faster? 3
like within
weeks?
a week.
Oh, okay.
I'm a bit pushy, but
So I think, Azrul, just to add on to that, I think she just mentioned the word pushy.
Pushy.
Pushy, and
As
you
in the
have a
specialist is
conscience.
pushy.
You have a conscience and you're pushy. Therefore, your patient gets the test done quickly.
Really?
Yeah. But the problem is, not everybody will have the conscience or is pushy enough to get that result, the test done quickly. So that's why I was saying about why not just strengthen the health system by using managers, specific cancer managers within the hospitals to navigate and to also ensure that the appointments are early. Because if you talk nicely to the radiologists, and we are all very friendly with our radiologists are very good
It's
to
a
us.
best friend, the
Best
radiologist.
We can get our dates done quickly, within a week, within 2 weeks. But we have to take the extra effort of doing that. And that takes you away from a consultation with another patient. But if you have cancer managers that are running to facilitate the patients throughout their journey. And I don't think it's a big investment, Yeah. So that is something that hopefully, we are trying to do it in UMMC, but we are still a bit behind with the project. But that is something that with not much additional investment, you actually get the impact of the care.
Sorry, Prof, you wanted to say something?
I also think that outsourcing to private, when sometimes, of course, in a busy hospital or certain hospital may not have the facility, I think the government should think of outsourcing it to private hospital. And also, like what Prof. Aishah, I think that's a very good idea to also to identify those who actually make a difference by having an earlier scan, all right? Not everyone will benefit from an earlier scan, and not everyone will benefit from having to repeat scan many times. So I think by streamlining who needs it urgently, who needs it, and then if it's still short, if the certain place may not have the facility, then outsourcing will be a good idea.
It's certainly making use of resources that are just laying there unutilized, right? And in the private sector especially. Thank you. And this is something of a recommendation that has been repeatedly emphasized. And we saw that during COVID-19 when you were forced to use that kind of modality. So we know it works and it can be done today.
Actually, they're already doing it. So for example,
Yes,
the
that's
screening
true, that's
programs,
true,
right?
yeah.
So the mammogram screening programs are actually run in the private sector by the Ministry of Women's, right? So it's already happening, but how do you strengthen that?
Yeah. And most importantly, get uptake. Make sure that
Yes.
patients come forward. So, Prof, Fuad, I'm going to ask you I think it's a bit controversial when we talk about cancer. It seems that we cannot run away from the issue of alternative therapy, traditional medicine, where we find that a lot of patients, after they get the first diagnosis, I've heard it also for lymphoma, for, blood cancers as well, also as solid tumors, where they get screened, they get diagnosed, it's timely. They know exactly which stage they are, and then they drop out and prefer to go for traditional medicine or complementary therapy. And several months later, you see them back in, they have deteriorated, their stages have progressed, and they are now at a different stage than when they were first diagnosed. Is this a common problem amongst certain types of cancers? And is there a way for us to address this issue? Because it seems like if you look at it from an ethnic group perspective, it seems to be very common. All ethnic groups are similar, but it might be that certain cancers people feel needs a different kind of approach. Prof. Fuad.
Yeah, it's still a very common problem, and with certain cancers more so. I think breast will be one of them. So many years ago, Ministry held a campaign saying that early diagnosis saves lives. And I said, early diagnosis saves nothing, they don't come for treatment. And that still reigns true. So we have certain tumors, breast, they don't want to lose the breast. Colorectal, they don't want to have a bag. So we realized this problem when we gave radiotherapy before surgery. Many patients felt better, then they disappear. A quarter of patients didn't come for treatment because they felt normal. But the cancer is still there, the roots are still there. So as Aishah said, the efficiency will be Just get somebody, a nurse or something, to call the patient, bug them, come for treatment, rather than spend more money on more machines and so on. So that's where the gap is. So you have to analyze, where is your problem? Patients are not coming for treatment. The advocacy groups, that may help us also. Patient who, I've had treatment with this person, he's very good, okay. It's like you go shopping, you do all your research and all that, then you ask your friend, what did he buy? Then you follow what he bought.
For real.
Something like that.
So you don't listen to your doctor, you listen to your relative
Exactly,
or
yeah.
a fellow patient or maybe the uncle next door. So really, this is how decisions are made? I mean, Prof. Gingyun?
I think yes, probably a little bit of that. But I think in the Klang Valley or in the West Coast, probably that problem, I think for blood cancers are not as common as, is not so rampant in that sense. But the East Coast, from what I heard from my colleague, they really literally get diagnosed and then they disappeared. So by the time they come back, they really are at the later stage. I think it's also a cultural belief and how they were brought up. And of course, in the East Coast, if you have not enough treatment center, because to get treated, they have to spend money, perhaps to travel. If they are young, they have to stop work when they feel quite well. And of course, alternative medicine always promise you no side effect and with cure. So, I mean, it is obviously sometimes that's what they want, right? And so I think it is not just they don't want to be treated, but perhaps there are also other situations that they find it difficult for them to access treatment as well, especially in East Malaysia, for example, as well as the East Coast.
So it's also got to do with treatment accessibility, even affected possibly by geographical limitations, but also non-medical issues as well. The fact that you can't get off from work, the fact that you can't stay to complete the regime which is necessary, and therefore your dependence is going to be on some alternative form, right?
You see, Azrul, I did a study on 19 women who present with very advanced disease. This is like more than 10 years ago. And I'm still sad today that I still see the same thing in clinic. But you could say that the reasons are multiple, but if you follow a framework and you make sure that when you talk to the patient, they know, you sort of sort out these things for them. One, literacy. Do they really know about the treatments that they're going to undergo? Most of them are so scared about chemotherapy, they didn't know that the hair would grow again, you know? And nobody told them.
They didn't know that the hair will grow
again. So that's why they don't want to have the treatments. So we don't have that type of support, you know, in our services, like an officer who does the education. We do have, but it's very patchy. So we try to have our breast care nurses do this part, you know, the literacy about the disease, literacy about the treatments. So that is not well covered. There is no person that can be designated this job. You know, the nurses are also busy doing something else. Okay, and then the other thing is the resources that the patient have. Do they have the finances, and do they have the coping skills to go through that period? Because that period is horrendous. You know, for most people, they will go through this very bad period of, and there's no psychosocial support. And do our doctors communicate well with the patients? That may also be a problem, where patients lack trust of the medical health system to be able to follow through the treatments. Okay, and the last one is who makes the decision? Is that really the patient or is it the family? You know, so not being aware of these things when you're talking to the patient may actually make that patient suddenly disappear. But it doesn't work all the time.
Well, this is very important because obviously treatment outcomes are being affected by non-medical issues, and this includes also societal norms, but also even the level of counseling that they get, oncopsychological support, you know, and this is something that when you look in terms of the continuum of care, maybe we still have a lot to go, you know.
There's none of these people who would have a career pathway in our public hospitals. So we don't have psychologists, and their career pathway is quite stunted in that way. They don't have posts for these people, so it's very difficult.
Yeah, so, yes, Prof.
Yeah, can I just add on to what we were talking about, the screening and patients coming, because this in a way pertains to the question on the akta fee, perintah fee.
Yeah.
So what happens is some patients, they've got a little bit of money, they got something. Then they take the initiative, go to the private, get a quick CT scan, get biopsy, get the diagnosis, and then you punish them. Because they've come from private, you charge them first class rate. They don't have the money. I spend that little bit that I have. So we need to get away from this because they took the initiative to look after their health and you punish them. So it's very unfair. So the akta fee is something that's really, I feel really bad. I think
It really is needed to incentivize people really to come forward to get treated, but then, but also to take care of themselves. We ask people to take insurance. We ask people to take care of themselves. We ask people to basically don't depend on government healthcare services for treatment. And then after that, when they run out of money, they have no more options and go back to government service. And we charge them with first class as if they were rich. So there's a problem there, and it definitely needs to be addressed. And I'm hoping that, you know, with the promise that was made, Prof. Aishah, the promise was made that it would be changed, you know, that it would be fulfilled. So we talk about meeting the promise of cancer care, right? So this is what it is. So we have a question here on Slido concerning what you would like to bring in if you were talking about biosimilars, you know, I mean,
yeah.
in Malaysia, what is most needed? If you were to name one, so I'll ask each of you one. So, Prof. Fuad, what would you like to see?
Well, actually,
or even an
innovator drug, yeah. But the WHO essential drug list is actually very interesting. So I think we should use that, what WHO already has identified. So in the last iteration, the one that I looked at, they at that time identified 3 drugs. They had trastuzumab or Herceptin, they had rituximab, and they had a third biosimilar. I think it was the growth factor. So at that point, the reason the WHO put that was that this was just coming to the end of their patent. So then they know that this should be prioritized because it's going to become a lot cheaper. So rather than a wish list, I think that's a very good benchmark what the WHO has deemed as essential. And the WHO essential list now is not all just the old drugs. Some of the new innovator drugs which is coming to the end of their patent lives are coming in.
Prof. Gingit? Just one drug. I mean, if you wanted to bring in today, what would be a priority for you? Can be innovator, biosimilar.
I think it will be a second generation tyrosine kinase for chronic myeloid leukemia.
For CML?
Correct. Although we have now first generation, but there are still perhaps, because now people are looking at, you can perhaps stop the TKI if you can achieve it a very deep response, then there's a possibility of stopping, and a second generation will probably better in that sense, well, from clinical trials anyway. So perhaps then you can then free up some money for something else. That's maybe something.
Okay. Thank you. Prof. Aishah, I know trastuzumab was a recent development which happened in the past, 2 years, right? 3 years?
No, it was 2014, I think, right? It has been it was no longer patented for quite some time, but we took a while to get it into the country, and it took a while for the prices to come down further. Okay. So there's a lot of, there are a lot of activities, I think, among the survivors and the cancer groups trying to bring, through their networks, information to manufacturers internationally, locally, to see whether people want to bring in the drugs.
So what's on your wish list?
For me, I think it's difficult because most of them are patented at the moment.
Well, it's okay. We expand it, so it includes innovative drugs as well. So what would it be for you?
You see, there's so many newer drugs that are has less problematic quality of life issues. So for example, if somebody has metastatic disease, right, and they might have what we call visceral crisis, that means they need to be treated quickly. And what if they didn't have to have chemo? So for people who are hormone sensitive type of breast cancer, there are alternatives to that, right? So there's CDK4/6 inhibitors and all that, and those are still quite expensive at the moment.
Okay, so We have some more questions here. There is, I think we'll go with, I think there's a very interesting question on private health insurers. We're actually going to have a presentation on insurance tomorrow, so I do hope people tune into this. But let me just ask this question to you all concerning how do you think that private health insurers could contribute more in terms of cancer financing? And right now, as you know, screening is not covered by insurance, and it's only after you've been diagnosed that insurance covers. So what do you think should change when it comes to this? Do you think screening diagnosis should be covered as well, or
I think
status quo is okay?
You see, for breast cancer anyway, you see the problem in Malaysia that anything goes in the market, in the marketplace, you can get an ultrasound easily, right? So a lot of young women who do not need to be screened, unless they've got a very strong family history or something, then you would probably do screening in this group of people. These people end up with ultrasound breasts and they find benign changes. And what happens to them? They will not get covered for breast cancer. So they won't be able to get their insurance, and they might have to wait another 2 years before they can actually get insured for breast cancer. So there's a lot of misunderstanding, I think. So I think the local insurance companies need to be more aware of the issues, and there should be some way that we can feed back to them, that the policies that they're doing is not helpful. And maybe even most of the treatments now are done in the daycare procedure or even outpatient procedure, and yet they cannot claim because they have to be admitted. So people become creative in admissions, which is very, So there are a lot of things like that requires a lot of maybe, discussions and change in policy. But I have to say the insurance company maybe have responded better. So like for some insurance companies, they do cover reconstruction and all that. But still, there's so many more that don't.
Prof. Gingen, in respect to blood cancers, insurance, how is it like?
I think one of the things that Prof. Aishah had mentioned is that a lot of time our treatment can be outpatient, and yet the insurance company make it really difficult wanting them to be admitted. And sometimes the ward is full, so that's not a very wise thing to do. And secondly, in stem cell transplantation or bone marrow transplantation is actually a curative, but some insurance company actually limit certain disease that they will say, oh, you can't have transplantation. But in a lot of blood cancers, stem cell transplantation can be curative, or at least in certain cases, it will increase the progression-free survival.
Okay, thank you. There is a question on Slido actually for you, Prof. Gan. Concerning your slide, looking at wanting more clinical trials and more R&D, but at the same time, here we are talking also about biosimilars, generics, and so forth. So how do we balance that out? Because at the end of the day, you still need investment for innovation, and we have to have certain incentives for that to happen. So how do we balance that out?
I'm actually very pro clinical trial and R&D. I think I understand that there is a lot of cost in conducting a clinical trial, and there are many costs involved in R&D in innovative drugs. I hope they do not misunderstood me, but what I'm saying is that once the drugs has been off patent, that we should think about bringing in biosimilar. And even with that, the pharmaceutical company should also think of, which they are, some of them, having creative way of having assistance program. But I think it is also important to understand the socio-economic situation of our patients, and whether they can perhaps find other ways to help the patient. As in clinical trials, obviously it would be something that is innovative. It would not be obviously, biosimilar on generic will not be an innovative drug. It would have been in the market for a while. So clinical trials definitely play a huge role, especially in cancer patients. And in blood cancers, as I've mentioned, there's many new innovative therapy. And I think that is something that we would like to see more in Malaysia.
Thank you, Prof. Gan. And I think it's clear, where your position is on this issue. And it's important because it does play a role in terms of making sure that we are able to learn from what has worked and, most importantly, informed on the innovation that appears in the future. So there's an interesting question here which I'll ask for Fuad, which is concerning the ability to access advanced cancer treatment, in this case, the CAR T-cell treatments that mentioned just now. I mean, how easy, or let's not say easy, but how accessible is it to have access to some of these newer treatments as within your context, within your hospital, for example?
Many of the advanced treatments is actually quite difficult. You can get some of the newer drugs through the ministry. So for those who are pensioners and so on, they do get access to some of the new drugs, but there's a lot of forms you have to fill in for approvals and so on. So for some of them, it takes months to get approval and maybe too late for them. CAR T-cell, I am not sure whether our hematologist is starting to do some trials on this, but this is, it's not so easy. Some are available, but in general, it's not so easy to get the latest treatments across.
Okay, I mean, it's one of the things that we generally acknowledge, and definitely at the end of the day, we see that it was also restrained by resources and also the offers by industry, for example, in wanting to put forward some of those new treatments to be accessible, maybe through special patient access schemes and so forth. Prof. Gan, did you want to contribute to that particular answer, because you do work
I
on
just
that.
wanted to mention about CAR T-cell. I think it is very in thing, and I think UKM is doing some clinical trial on CAR T-cell, but otherwise all the public hospital, even in our hospital, we do not provide CAR T-cell. It's quite it's not that complicated if we have the facility built, because you need a GMP lab, and you need that GMP lab that is allowed viral vector. So, but if we can collaborate with either private or other overseas institution, that it is something that it is feasible if there is a desire to do so for public hospital or even academic centers.
So it's really about interest and
the will to focus and to want it, yes. And I think CAR T cells has shown relatively good results for leukemia patients and now multiple myeloma, and there are also quite a number of clinical studies looking at CAR T cells for solid tumor as well. So I think personally, I think it's a good investment for the government to think about investing in this. Yeah.
Thank you. And this echoes back to what the health minister said last year in one of the cancer conferences that we organized, which is looking at health as an investment. It's not an expenditure, it's really an investment for the well-being of the country. I wanted to, on that note, I want to actually ask before we go to closing statements is really this soalan, again, another soalan cepu mas, which is concerning how we've been informed again and again, and most recently has been indicated that we are underfunding, we are underinvesting in our healthcare system. We're not spending enough. It is still below what it should be, which is several points higher on the GDP. And today we have the highest budget that's been allocated under the federal budget is 32 billion ringgit. And I was joking with the Deputy Health Minister just now, but the honest truth is the next budget is going to be coming soon, and we're going to have to argue for more. And the reality here is that we're still not budgeting enough. So the question is, in your your presentation, Prof, it's never enough under the greatest showman just now. So in your respective beliefs, I mean, in very short, what do you think the government should do in terms of answering this question of how much is necessary, how much is needed when it comes to healthcare? What should they use as benchmark? Prof. Fuad.
Wow, soalan cepu mas. Literally a must this time. Yeah. Yes, I think we should use the international standards as a benchmark. 8% of UK GDP obviously is quite different from our 8%, but it's still something for us to aim at. And today, very interestingly, on BFM, they said that we want to increase the minimum wage to 1,005. But I said, please don't increase too fast. Do it for 1,003. And so that's our target. So we should say that maybe every year we will increase by not much, maybe 0.3%. So that within, say, 5 years, it will be now 5.5 instead of 4. So that should be our target. Just increase a little bit every year, so that we can cut some of these gaps. But even with that increase, we still must learn that we need to spend it wisely. You need to spend it a bit more on this, a bit more on that. And as what Aishah said, doesn't mean the person who shouts the loudest should get the most money. Where is it needed? Not just to your friend or the one who's been bugging you every day with the phone calls. I think that's very important.
Thank you, Prof. Professor, how do we determine the amount that's needed?
I think there has to be some form of planning, budgeting. Remember what we talked about, the limited care, enhanced care, and the basic care, or the maximal care. Those work has been done already, So I think there could be a very good planning on to how much money we really need if you want to achieve, let's say, enhanced care in Malaysia, or maximal care, or even basic care for some places.
So it's the level of healthcare that you want, and then see where the gap is between what you want versus where we are today.
Or even plan for even like places where it's inaccessible. You may actually have a better thing of just having good quality basic cancer care.
Okay.
And it could be actually, something more achievable than what we're trying to do now, when we're trying to go like from A to Z, when we should be going, as what Prof. Fuad said, slowly, incremental. But it has to be planned. It cannot be something you're planning for the next 4 years. It has to be something like 20 years planning, something like that.
Thanks, Prof. Prof. Kingen.
Well, I tend to agree with both of them, and I think Prof. what he has mentioned about value added, I think it should be, I think if everyone want to ask for the sky, but I think in reality we can't. So I think we should look at what are the value added things that we can do, that whatever that we spend on will translate into significant benefit, not just survival, but as well as quality of life as well.
Health outcomes with clear indicators.
So those are the outcomes that we need to define. Is it just survival but with poor quality of life, or good survival as well as good quality of life? So I think that is something that we need to define. And then again, as both of our esteemed panelists have mentioned, basically we need to plan, and it can't be from 4% to 13%, for example. So we have to be realistic.
So guided again by value-based healthcare. We're looking at decision-making that's value-based.
I think the investment in implementation science and having to improve quality, how do you do that? Like, at the moment, we are not thinking in small incremental steps. In fact, just putting a nurse, for example, in the cancer service, just to make sure that things are done quickly and efficiently, may actually be a small, not even an investment. It's like, just a rechanneling of resources.
Okay,
Yeah.
Thank you, Professor. So we're literally coming to the final seconds of the session. So I wanted to give a chance for all our panelists to give their last thoughts before we close for today. And you have 30 seconds, Prof. Gingen, your final thoughts on today's discussion. Go ahead.
I would say that my wish, put it that way, I think my wish is for the policymaker, the stakeholder, and to understand what are our gaps and to be determined to improve our patients' care and not just survival, but also quality of life.
Thank you. I think that's a really important point there. And I'm glad that we gotten a positive response from the Deputy Health Minister just now, who's very keen to find out the outputs from this meeting in the next couple of days. Prof. Aishah, 30 seconds.
We have the Cancer Control Strategic Plan document that has been published recently for 2021 to 25. So now we all have to do is to implement it, and we have to work together. And I think we need to use evidence to move forward. That means there should be many pilots going around the country looking at best practices, how we can do things better with what we have, with the current resources we have.
Thank you, Prof. Aishah. And Prof. Fuad, the final word.
Yeah, I think in terms of healthcare, Malaysia's healthcare system is really ranked quite highly throughout the world. So we already have a good system. What we need to do is plug the gaps and see where we are wasting and, plug those gaps as well. So I think we get a lot more for a little bit of extra investments rather than looking at the sky. Right now, we need to crawl first.
So we have to be realistic, but at the same time, be aspirational. Be looking at the next, or the other side of the hill, looking at how we can do better. And we have good examples to look at that. So I would like to just say thank you to all of our three panelists here today. It's been a very interesting topic. It's been really insightful with so many new information, but also I think some of the feedback that we've already started to see on Slido is that people want to continue on this conversation and also to find a way for it to be extended into tomorrow's session. So I'm going to KIV some of these questions and bring it over to tomorrow. So I just wanted to remind all of our viewers out there who are attending today's session for you to join us for tomorrow's continuation of the summit, where we are starting. If we could just pull up the agenda for tomorrow, pull up on the screen to just show what's on, so that basically some of the issues that we've touched on today, we're going to be extending further into issues like insurance, for example, continuing on that conversation. We have patient navigation, which is going to be discussed by a practitioner who is involved in the process. And most importantly, we're going to hear also the patient voice who are basically going to be telling their side of their experience of the patient journey when it comes to cancer care. And most importantly, where are the gaps and where we can improve upon. So please don't forget to join us tomorrow at 10. What time is it going to be? It's going to be at 10 a.m. tomorrow. So please log in again using the same login that you used today for tomorrow's session as well. So with that, we will end day one of the Oncology Summit 2022, and I do hope that you'll join us again for tomorrow at 10 a.m. With that, my name is Azrul Maqalib from the Galen Centre for Health and Social Policy, signing off. And to those who are fasting today, I wish you all a good breaking fast. And for those of you who are not fasting, well, you can just watch us break fast. So have a good dinner, and I'll see you all tomorrow morning. Thank you. Assalamualaikum warahmatullahi wabarakatuh, and a very good day.